The thing about the veins, you guys, is, again, you want to start looking at these and visualizing this, how this is taking place. Veins start out small and empty into bigger veins, into bigger veins. So it's like a creek turning into a bigger creek, into a river. And so just visualize that. And so a lot of times when you're talking about these, we're talking about what does one vein empty into another one, okay? Or this vein receives blood from what other two veins, okay? And so you really want to visualize it that way because it really helps. The other thing about the veins is more often than not, they're going to have the same name as the artery that they're sitting next to, because arteries and veins and nerves run together in what's called a neurovascular bundle. And normally you would have the same name, but not always. And so you really want to learn the exceptions, okay? And we'll point the exceptions out to you, okay? So on here, we're starting out in the brain and working our way down. Notice how when we talked about arteries, where did we start at? We started at the heart and worked out. So we're really talking about coming out peripherally and coming back to the heart. And so that's how you want to start viewing them, okay? And again, when you learn the arteries, you're starting at the heart and you're seeing what does it branch into? What is it, or this is a branch of that, okay? So starting in the brain, this is going to help you with the answer in one of your homework questions. One of them, you had to come from the left ventricle, go through the brain, and get back to the heart. And so you've got to go from arteries into basically arterioles, into a capillary bed, and now you got to get drainage. The way the brain drains is in those dural sinuses first, okay? And so you remember the superior sagittal and inferior sagittal sinuses, right? They were right here and here. You saw them best on this model. You also saw them on the half head, if you remember. The superior sagittal sinus here, okay? So the only one I've added there is the sigmoid sinus, and we don't have a great model that shows it, but I want you to know it because that's what drains right out of the brain. And on this model here, it's what's this little curve right here that's draining into this hole that my Q-tip is in right now. And what hole is that Q-tip is in? The jugular foramen. It's called that because that's where your blood drains out of your brain here. And so it's coming through this sigmoid sinus into that jugular foramen, okay? And the jugular foramen then is going to form the internal jugular vein, okay, the IJ. And the internal jugular vein is right here on this one. And what it's doing is joining up with the subclavian vein. See how the subclavian's coming in? The right subclavian, here's the right internal jugular. And it's going to form this right brachiocephalic vein. Over here, this is the left subclavian. And this little spot where it's coming in here would be the internal jugular on this side. Okay? So that's the IJ, internal jugular. You have... And so that vein runs right next to what artery?
The
Common carotid. And up higher, right next to the internal carotid. This is one of the exceptions. You don't have a internal or external carotid vein. You don't have a common carotid vein. It's the internal jugular. Okay? So that's one of the exceptions right there. The other vein that you have, the other thing about veins is you have superficial veins. We didn't talk about superficial arteries, okay, because you don't have them. And we'll talk about that and the reason why in a second. You have a superficial jugular vein. It's called the external jugular. It's on top of your sternocleidomastoid. That's the vein that dilates and people get mad, right there. You can see it there. Here it is right here. Okay.
What's that one called?
External jugular.
Oh.
And here it is here. Okay. This actually vein is used, you guys, in diagnoses for it's a poor man's way of diagnosing congestive heart failure.
That's what my uncle was saying.
What's that?
My uncle, he walked into the heart office and he looked at him and just said,
Right.
I mean, they ran other tests, but
Yeah.
initially he was just like,
And the way you tell is you put somebody at a 45-degree angle. So you have them sit there at a 45-degree angle, and you can measure, you can see the pulse, the back pulse in the jugular. You can see it fill up. And if it's up too high, you know they have a failure. So it's used as a diagnostic test. So And you can see here that external jugular is dumping right here into the subclavian. That's the internal jugular coming in here, external jugular. Now, subclavian, internal jugular come together to form the brachiocephalic. You have a right brachiocephalic right here and a left. Remember on the artery you only had one, but now in the veins you have a right and a left brachiocephalic.
So the brachiocephalic is just going to be median to the jugulars?
It's this,
This,
the jugular is emptying into it with the subclavian. So it starts here
Okay.
and it ends here.
So both the jugular veins empty into the
Into a brachiocephalic, yeah. See here? This one's emptying in here, okay? And both these brachiocephalics empty into the superior vena cava right here, which then empties into the right atrium. Okay? So, who's going into nursing? A few of you? Okay. So, one of the things, especially if you're in the ICU, even if you're on the floor, you're going to take care of central lines. Central lines call that because it's a catheter, it's an IV catheter. A normal IV catheter would just go into a vein a little ways. A central line goes all the way to where the tip of the catheter is right here or right to going into the atrium. And there's reasons for that you'll learn later. The two most common central lines that are put in are subclavians and IJs, or internal jugulars. Now, you have to take care of them. The one that's easiest to take care of is the subclavian because the needle, the catheter goes right here, and you just coil up the rest of it and put a little dressing on it here. It sits real nice and doesn't bother anybody. An IJ is going to come out of the neck, and you got to wrap it around the ear, and the patient's going to be moving his neck, and it's just, it's a hassle to take care of. It's harder to keep on, okay? And so you'll see the difference between managing those. The people that put these in is anesthesiologists, put in IJs. They don't even know how to put, they know how to put subclavians in, but they rarely put them in. Whereas, like, I would put mostly subclavians in, and a lot of other people would. Why would you think the anesthesiologist would only put in internal jugular central lines?
because the patient is sedated.
Patient is sedated.
Probably just easier if the patient isn't moving around.
Well, not so much that, but you're on the right track a little bit. You've got to understand where the anesthesiologist hangs out at.
Like at the head.
Yeah, he just hangs out here. So here's the person laying down. Here's the head. This is where he's at. And the arms on the patient is usually out like this on an operating room table. And so it's too hard for him to walk around because a lot of times they're draped and he can't get around this side to put the subclavian in. It's too hard to put it in from above. And so they just put IJs in real quick. And they're really good at it. Because that one, you don't see it. You can't see the vessel. You can't see the subclavian either. You just got to know the landmarks to stick it in. So that's why you'll see those guys just putting IJs in. Inferior vena cava. Remember you guys saw that on the heart? Okay, on those hearts over there. And so as you look at it, here's the right atrium. Here's the superior vena cava. Here's that inferior vena cava coming in. So all you saw was this little bit that was emptying into the heart before, right? So what really happens is it sits like this. Okay? So here, inferior vena cava, this whole big blue one is inferior vena cava. Okay? In this part, the liver's kind of wrapping around it here. Okay? Inferior vena cava. So, all inferior vena cava here, and coming into the atrium here, inferior vena cava. Okay? Or it's more fondly called Mr. Big Blue. Okay?
Big blue.
Yeah. Pulmonary veins, are we okay with those?
No.
Remember, those are what's bringing oxygenated blood back. So here they are here. Remember coming back in the left atrium? And is this the pulmonary vein here?
No.
No, it's the pulmonary artery. Remember, it's opposite colors up here. This is the pulmonary vein. Same thing over here on this guy. Pulmonary veins are the red ones. Okay. because they got fresh oxygenated blood bringing it back to the left atrium. Okay. Superficial veins of the arm. These are veins, you guys, that are between the skin and the fascia on the muscle. You see bodybuilders, their veins are really big. Those are superficial veins. Do we have superficial arteries?
No.
No. Why?
Closer to the heart.
Right, protective. I mean, it would be very easy to cut it then, and dealing with an arterial bleed is a lot harder. You can die from that real quick. So you don't really have superficial arteries, thank God, okay? But you need superficial veins in order to drain the skin and everything, okay? And so the ones none of the models show them that great, but let me kind of explain where they're at, and I'll show you where you can see a little bit of them. So for the upper extremity, the three of them are cephalic, basilic, and the median cubital. So if you look at the arm, the cephalic superficial veins on the lateral side coming up like this. The basilic's on the medial side coming up like this. Mm-hmm. And that median cubital, that's where you get blood drawn, right here. Okay? So with that said, this right here is a cephalic coming in here. Right here. Okay? Now it would come down the arm too, but this is just a part of it. This here is the basilic. Now, if you go to the key over there, there's two numbers here. There's a number here and a number here. They'll say this portion is the basilic, this portion here is the axillary. That's not anatomically correct. Your axillary artery is much deeper. But this is how they made the model. For our purposes, we're just going to say this is basilic. Okay?
Basilic.
Yeah. Now, this model here shows them also. These are your superficial veins here. The deep arteries and veins are running together down in here. And so this is the lateral side of the arm, so this would be that cephalic vein right here. This would be the basilic vein, and these would be those median cubitals right here. Okay? We okay with that? Just a side note. If you think about where your arteries are running and access to them, they're kind of in places almost where you have joints. Not so much here in the arm, because by then that brachial arteries kind of has divided out into the radial and the ulna. But the femoral artery right here in the groin, that's how you get to it here. The popliteal behind the knee, behind the joint. The common carotids are in a joint that you can flex. If you think about the exposures of those, they all can be protected by balling up. So you can roll your wrist down, close your elbows, bring your axillary in, close your groin and this, and ball up and have protection. You don't have any arteries exposed in your back or any place in the back of your arms. And so that's sort of a protective mechanism, to be able to do that.
Is that why you have that reflex?
That's how, you have that reflex, and to kind of bring your head down and protect things so that something's trying to get to your arteries isn't going to get to them as easy that way.
Is that why they tell you to lay down and ball up and pretend you're asleep if you run into a bear?
Exactly, because he's going to scratch you and bite you. You can still survive that, but if he gets your femoral artery, you're not.
Right.
And believe me, people bleed out from their femoral arteries. I know of 2 cases. One was a sheriff. This happened, I don't know how many years ago. He reaches into his truck, he's going to hunt, reaches in the truck, grabs his rifle, and shoots a 30-06 and hits himself in the femoral artery. And they find him there dead by the truck. He bled out. Yeah. The other one was a prisoner in Folsom.
What happened with that
He
one?
actually didn't die. He survived, but he almost died.
How did he get hurt?
Nope. Officer shot him.
What did he do?
Didn't do anything.
They never do anything.
This guy didn't. And he came in, I took care of him, and he was going, I didn't do anything. They shot me, I didn't do anything. I go, yeah, right. They all say that. About a year later, they got that guard and tried him and threw him in prison. He was on the catwalk across. The guy was in his cell, and the guard had mouthed off to some other guards and said, I'm going to shoot somebody today. And he just, a 223, an
With a
M16,
shirt.
the guy was sitting on the toilet, just shot him through the cell. And he was banking on the fact that nobody would believe him.
Poor guy.
And they took time getting him in, and he was almost dead. He was like the closest to dead that you can get. He was in the hospital like 2 weeks, 3 weeks. What's that? Oh, it is. You see crazy stuff like that. There's like the guy that came in, stabbed out of Folsom, and he's got stabbed in the belly in different places. So I'm consenting him to take him up to the OR to explore his abdomen. I go, well, now listen, man, if it hit your colon or something, we may have to give you a colostomy, And he goes, no, you don't have to do that. I go, no, you would, because, there's a lot of bugs in the colon. He goes, no, my colon's clean. He goes, no. I said, and he goes, no, you understand, Doc. I knew I was going to get stabbed a week ago, and so I went on clear liquids, and I took a bunch of enemas and stuff. And I got my colon real clean. I go, what? He goes, yeah. He goes, my colon's fine. You can sew it up. Yeah. We went in there. He didn't hit the colon, but I believed him too, man.
Give him
He knew it
benefit
was
of the
coming.
doubt.
And I go, well, weren't you afraid you're going to get killed? He goes, no, I knew I wouldn't get killed. They were going to teach me a lesson, that's all.
Oh my God.
It's a different world over there. Seriously, it's really weird, He goes, I even knew when it was going to happen. Where it was going to happen at probably. So, yeah, it's a strange world. Okay, we okay with the superficial veins?
Yes.
Okay, so the other ones are named after just the arteries they're running next to. We don't see them that good in the arm, okay? But what we could do is like point to the artery and ask you what vein's next to it, okay? And so the axillary vein would be next to the axillary artery and so forth, okay? So that's the ulna, radial, brachial, axillary. Subclavian, you see. Intercostals, you do see here. You can see the vein here on these and even on this one right here, okay? So you can see, yeah.
Are all 6 of those named after the arteries they run?
Right. Yeah, remember the arteries? If you go in the artery section, they're the same names. Okay, the next two, azygous and hemiazygous. This is ones we didn't see any arteries like this, did we?
No.
Okay, because there aren't any. There's just these veins, and these drain the intercostals predominantly. The azygous is on the right side, posterior chest. The hemiazygous is on the left. So as you look here, see this vein that's running up and down vertical right here? That's the azygous. Okay. Now, we can't see the hemiazygous on this side on this model, but it's over here. Here's the hemiazygous on the left side.
Why do they have different names? Why not just
Different locations. In fact, when you read your book, you're going to see that for the hemiazygous, you're going to see an accessory hemiazygous, but we're not going to go into that detail. So we're just going to say this is hemiazygous. And what they do is the hemiozyguses actually send up 2 branches, the accessory and hemi, send a branch over to drain into the zygous, is what they do. So you don't see the zygous on this side because, again, this model doesn't show it. So one model shows the azygous, the other one shows the hemiazygous.
Zygous.
Okay. The mesenteric veins, inferior, superior, they go right alongside of the artery.
Mesenteric artery.
And so here's the superior mesenteric vein, okay? And here was that inferior mesenteric artery. Here's the inferior mesenteric vein right here. It's off a little bit ways. It drains a little bit different how the artery comes out. It drains into the splenic vein is what it
What
drains
does
into.
the superior,
This is the inferior mesenteric.
that drains into splenic?
In the splenic, yeah. That I probably won't ask you.
Okay, thank you.
Okay, splenic vein. Remember this is the splenic artery? Mm-hmm. Here's the splenic veins coming out right here. Coming from the
I
spleen.
missed it.
Right there. What's that?
Red.
Well, red's the splenic artery.
Up there.
Here.
He's talking
She's talking about this.
This
Oh,
is
yeah.
a piece of the liver. And so the liver's sitting here, and this is just a hunk of it, and that's the gallbladder.
Yeah,
Okay.
that was kind
So splenic artery, splenic vein right here. Okay. What's that? Remember this one? The spleen's sitting here. That's the splenic artery. Here's the splenic vein right here. Okay. I think that's all I have on it. Okay, so now the next two. Hepatic portal vein, hepatic vein. You think you can mix those two up?
Yeah.
Yeah, easily, very easily. Now, remember I showed you guys the branch of the common hepatic artery. One of them was the hepatic artery proper. The other one was the gastroduodenal. Just to review that, they came off the ciliary trunk. Here was the common hepatic right here. So these hepatics you can get mixed up real easy. There's a lot of hepatics going here. And this was the hepatic artery proper right there, and that's going to the liver. And here is the gastroduodenal. Now, if you remember, the other place you saw the hepatic artery proper was here, where it's bringing fresh oxygenated blood into the liver, right there. Okay. Now, what happens is you are going to send fresh oxygenated blood into the small intestines through that superior mesenteric, inferior mesenteric. You're going to go through the capillaries in the small intestines and the colon, and you're going to lose oxygen. But at the same time, you're going to absorb nutrients into those veins and those capillaries. And they're going to drain through the inferior mesenteric, superior mesenteric. Those drain into the hepatic portal vein, which now comes into the liver right here and now forms another capillary bed, and it percolates through the liver. So what you have is the capillaries picking up things in the small intestines, going into a vein, into the hepatic portal vein, now going to the liver and making more capillaries. We saw a similar thing up in the pituitary, remember? So that's why it's called the hepatic portal vein. It's coming into the liver here. It's bringing unoxygenated blood, but rich in nutrients, things that you just absorbed in your bowel, into the liver. But the liver also is getting oxygenated blood from that hepatic artery proper. So the liver has two blood supplies coming into it. Okay? Usually a vein is draining the organ, right? So here the hepatic portal vein is bringing it in. Fresh unoxygenated blood, but rich in nutrients. And it's going to percolate through the liver, and your liver is going to remove things and all this. Actually, that arterial blood and hepatic portal vein mix. Okay, we're going to look at that in the digestive system. And they collect in the liver, and the liver has to drain. And the liver drains into the vena cava by the hepatic veins, and this is one of the hepatic veins here. You have three of them. The models just don't show the other ones. They're very short. They're very, very short. They just hook the liver into the vena cava. So you see the difference between the hepatic portal vein and the hepatic vein. The hepatic portal vein is bringing blood that came from the bowel, that's lost oxygen but picked up nutrients, and delivering it to the liver, and it percolates through the sinusoids of the liver. The hepatic vein is draining that liver into the vena cava, inferior vena cava. Okay? Those things are really short, and in deacceleration injuries, like you hit somebody, head on or something, you can rip that liver right off that vena cava. It's a terrible injury. It's tough to even manage because you can't get up in there under that diaphragm very easily. It's really tough. So people die from that. You just can rip your liver right off your vena cava. This doesn't show any of the hepatic veins, but they're in there. But this does show the hepatic portal vein right here, the blue one. The red one next to it would be the hepatic artery proper. Okay? And we'll go over this closer in digestion too, you guys. Okay? So that's something that's a little bit different. Renal veins, okay? Pretty simple. They're draining the kidneys. Here's the right renal vein. Here's the left. The one thing to note here, though, okay, is that left renal vein has farther to go, and it crosses over the abdominal aorta. See how it crosses on top of it here? Okay, so that's a little bit unique to get over to the vena cava. And you can see them here too. Right renal vein, left renal vein. Okay. The gonadal veins, they are draining the gonads. Here is the left, and the right is coming in the vena cava here. Now the thing that you need to notice here on this is the left gonadal vein here is not draining in the inferior vena cava. It's going up here and draining into the left renal vein. See how it comes up and drains there? Whereas the right gonadal drains into the inferior vena cava right there.
Good to know that specifically.
Yeah, you betcha. Yeah. You'll see it in your reading too, and we'll talk about it in lecture. So there's a difference in how the left drains versus the right. The left drains into the left renal vein, the right drains into the inferior vena cava. Okay, superficial veins of the leg. Do not have great models for that, but let me describe and I'll show you what we do have. You have a great saphenous, you guys, and a small saphenous, and sometimes you'll see it called the lesser saphenous. The greater saphenous vein is this vein that's superficial, that starts down here near the ankle, runs all the way up the medial side of the thigh, comes up here and empties into the femoral vein. It's the vein that gets harvested for coronary artery bypass grafts. They make a long cut, they strip it out, they tie the branches, and they have a thing that rips the valves out, and they use it then up in the heart. So, know where it's at, and the only place you really see it is right here. This would be the greater saphenous coming in right here on this medial side here. Don't really see it anyplace else. The lesser saphenous just drains the lower part of the leg up to the knee. You don't have it on the upper part, okay, but it's on the lateral side. We okay with that?
Yeah.
The grade saphenous, did I say? Is that, you said it's medial, but is it all the way down the leg?
Yeah, full length. Yeah. In fact, if they're going to use it for multiple bypasses, they'll strip the whole thing out, and the person will have a cut from here all the way to here with a leg wrap.
And they don't need that vein? Or...
Well, they can get a little edema and swelling and stuff. Yeah. Okay, the deep veins are the same, you guys. Posterior tibial, anterior tibial, popliteal, femoral veins. We do see a couple of these here.
Oh my God.
We don't see the anterior tibial or the posterior tibial, but you do see here the popliteal vein right here, okay, and the femoral vein right here. But as soon as it goes underneath that ligament, what is that vein right there?
Internal.
External iliac.
External.
External iliac. So you can see those external iliacs right here, here. Internal iliac, you can see a little piece of it there and here. Same thing here. External iliac, here and here. Internal iliac, there's a little hunk of it there. And then they form the common iliacs. Common iliacs dump into what? Inferior vena cava. Inferior vena cava. We okay with these? So, just for review, ones that are named after the artery, you can pick those up pretty quick. The oddball ones are the sinuses we looked at, the internal jugular, external jugular, two brachiocephalics, a right and a left, okay? Also, you have the superficial veins of the upper extremity, the cephalic, basilic, and median cubitals. You have those crasiozygoses and hemiozygoses. Vena cava is the inferior superior vena cava. That's different than the aorta, okay? And then the hepatic portal vein and the hepatic vein. We didn't see any arteries like that, okay? And then the superficial veins of the leg, the great saphenous, small saphenous. And just knowing the gonadal veins drain a little bit weird. The left one into the left renal, the right one into the inferior vena cava. Questions about those veins, you guys?
Did you mention where the tibial veins were?
Yeah, I don't think you know.
The posterior tibial?
They run along the artery.
Yeah, they just run right along the arteries. And again, we don't have them show them on any model.
So those last 7 are just all the same as arteries.
Right.
Okay.
Mm-hmm.
How do you count so fast?
Cool.
Yeah. Hey, turn your page, you guys, over to 41. We're behind in lecture a little bit, but I'll catch us up and I'll just start talking a lot quicker in lecture.
Just say whatever's on the test.
So, lymphatic. I'm going to take you through this real quick, and then you're going to have some study time. The histology I'll show you in a minute. That's not too hard. There's only about 3 things. Roman numeral 2, primary lymph organs. You need to understand that the 2 primary lymph organs in the body is bone marrow and thymus. And you guys remember that thymus, don't you? It sits on top of the heart. So those are what we call primary lymph organs. The rest of the lymph organs that we call secondary lymph organs. And those are things like lymph nodes, spleen, and lymphatic nodules. Okay, so lymph nodes. These are what people call glands in the neck, but they're not. You know better now, right? And you can see here cervical, axillary, pelvic, inguinal lymph nodes. Now, there's other lymph nodes. There's like a mediastinal lymph nodes, for example. There's bronchial lymph nodes. There's periaortic lymph nodes. The cervical lymph nodes actually have different regions and different names depending upon where they're at. So it's a little more complex. The inguinal lymph nodes, so for example, there's superficial inguinal lymph nodes, there's deep inguinal lymph nodes. For our purposes, we're going to look at these just 4 simple ones, okay? And those are the ones you're responsible for. Where you see them on the models is a couple of models. This guy here, you can see some rudimentary, sort of just a few cervical lymph nodes here. You actually would have them up in the neck, all up and down. The model just doesn't show it. But these up here, if we pointed to one of these green things here and asked you what it was, your answer would be cervical lymph node. If you just answer it lymph node, you're going to get half of it right. Okay? The little lines between them, the little green lines between them are lymph vessels. Okay? Here's your axillary lymph nodes here. Okay? Inguinal lymph nodes down here. The green ones here. And back in here, these gray ones on the right side, you'll see lymph nodes there. Those would be pelvic lymph nodes. Okay.
Where's the inguinal lymph node?
Where's the inguinal lymph nodes, guys? Point to.
Point to.
Where's your inguinal area? Point to your inguinal area.
I don't know. In here.
Right. So do you see them?
The green things.
Yeah.
Okay.
Okay.
Also.
See that pink torso? Somebody moved it. Sorry, let me move it for you. So this pink torso actually shows you some axillary inguinal lymph nodes too. Axillary, inguinal. Okay? So you can see them on that guy too. So those are, you okay with lymph nodes, you guys? Okay. Not too hard. Spleen. Remember where the spleen's at? On this model, here it is sticking out right here. Okay? This guy, here it is right here. Okay? On these torso models, they kind of hide it. Okay? They hook it in here with this lung. Here's the diaphragm. Here's the spleen right here. Okay? So 3 different spleens. Okay? Lymphatic nodules. What lymphatic nodules, you guys, are, they're not lymph nodes. Lymph nodes actually have lymph vessels coming into it, afferent, and then the lymph filters through it, and then it leaves it by efferent lymph vessels. Lymph nodules just start, and then they just drain lymph from there. And so they're really just a big collection of immune cells, mostly lymphocytes, and they're placed in very strategic locations where your body would get exposed to antigens or bacteria or viruses and stuff. And so one of them is the tonsils, okay? And so these tonsils, and you can see them there, you have a pharyngeal tonsil, 2 palatine tonsils, and a lingual tonsil, okay? And we're going to look at these in respiratory also, and I'll show you later down the road on the big nose model where they're at too. But right here, this would be your palatine tonsil. That's the one that you look at in the back of your mouth, you know, and you have one on both sides. Does anybody here have those removed? Okay, I have too. We don't remove them as much as we used to. Now, in the back of the nasal cavity here is one big tonsil here, and that's the pharyngeal tonsil. You'll hear it by its more common name, the adenoids. Anybody have their adenoids out? Me too.
Jeez.
The adenoids can get so big that they block the nasal pharynx right here, and you can't breathe through your nose. So if you have a little kid that all of a sudden is a mouth breather, is breathing through his mouth, you need to take him and see, is he having a problem? He can't breathe. Because if he breathes long enough through his mouth, he'll habitually become a mouth breather. Now, I'm habitually a mouth breather because of that. Because my parents weren't sophisticated. And so their response, my dad's response to me breathing, walking around with my mouth open was to, bam, close your mouth. Bam, close your mouth.
Jeez.
So I'd close it and turn red, and then he'd walk away. And it wasn't until my palatine tonsils got big, and I was having sore throats, and they go, oh, well, now we got to do something. And the doctor like going, you know, you really need these adenoids out. So you can psychologically traumatize your kids.
Is that how you get sleep apnea also?
Not really, no. No, that's a little different. That's where the tongue and everything kind of collapses and blocks it off here. So lingual tonsil, we don't see it really good, but it would be at the base of the tongue, sort of that tissue right there. Okay. So these are the tonsils. You can see they're strategically located where things are coming in. Like as you breathe, it's going to hit this. Okay. Same thing as you eat, it's going to go past these palatine tonsils. So they're there for that. Appendix. Who's had their appendix out? One. Just that's it. So here's your appendix. And when we do GI, we'll actually give it its formal name. It's a variform appendix. Variform appendix. And
Just the little green piece?
yeah. And here it is here, hanging down here like a little finger here.
Do we even know what it does, or just?
We're going to talk about that in digestion.
Where is it on?
What's that?
Where is it on here?
Right there. The little Peyer's patches.
Okay.
Appendix. Did they take it out through little holes or big holes? They take it out through little holes or big hole? Do you get it laparoscopically, or do they make a big, just a big cut? Yeah. We take those out through the laparoscope mostly now. I actually had it was about 3 years ago. A girl walked into class, was taking the class from me about the second week. She comes up to me. She's like 24 or 25. She goes, Dr. Pickle, you took my appendix out when I was 7.
Oh my gosh.
And I go, really? Show me your scar. She goes, yeah, see?
That's crazy.
You know, she was really happy with it. I was happy, she was happy. Okay, so we're going to do GI. This is a model of a common wall of the intestines. And there's something called Peyer's patches where you have lymphatic tissue, and they're kind of there guarding from things getting in. And that's what this blue thing is right here. So this is a Peyer's patch right here. That's a Peyer's patch. Okay? Now, what we're going to look at in lecture is that you collect lymph from the tissue. If you didn't collect lymph, you would be edematous. This is a way to get extra interstitial fluid back into the blood, okay? And all these lymph vessels collect and drain back into 2 locations. And right where the crotches meet between the subclavian vein and the internal jugular. And on the right side is going to be the right thoracic duct. We don't see it here, but that's where it would be located. It's going to drain basically 1/4 of your lymph. 3/4 of your lymph is drained by a large lymphatic vessel called the thoracic duct. And it empties in right here, and that's it right there in green. We love this thing. You see it right here. That is your thoracic duct emptying in right there. Okay? You want to make sure you know that one. Everybody okay with the thoracic duct? Okay.
Little green thing.
So let me walk you guys up and show you these slides.
Oh my gosh. Can we turn off this light or something because it has a glare on it?
That's from outside though.
Oh, it is?
No, it's not.
It's I see the lights here.
We can try that.
Well, the glare I see is from outside.
We'll come over here because it's the light.
To be shorter, Christian.
Yeah, you have to
Yeah.
be shorter.
Yeah, see,
That's
it's still a glare.
that's
Is that better?
well. There's those glares too. You have to turn all of them off. If you don't mind,
She's just being pissed.
This is
No,
what
not.
you're going to get.
See, that made the glare worse.
because it's like no, it didn't.
Okay, so
There we go.
there's a slide tray over there, you guys, 12-9,
Perfect.
okay? And it's lymphatic vessels and valves. These are all like capillaries. This is a big lymphatic vessel, and you can see the valve right here. Okay, but darken it now. I don't know if you can see it better. Do you see this little V right here? Okay, so if we point an arrow to you to that and ask you what that is, what are you going to tell me? Lymphatic valve inside of a lymph vessel. Okay? We okay with that? Okay. So that one's not too hard.
Mine, look at,
Because now
it's just all white.
Yeah.
Oh.
You just have to tap the screen where the slide is.
It doesn't work for video.
On your iPhone 5? Is that a 5? Oh.
Okay, so this, you guys, is the
That's
lowest
really
power I can get, and this is your lymph node. Is a lymph node. It has a capsule around it. You can see the capsule on the outside. Some of those over there you might be able to find where you actually see the lymph vessels coming in or leaving. There's different parts of it. I'm not going to get picky about it. There's actually what's called a hilum. But on the outer part of it is the cortex. And you will see these like round areas like this. Okay. These are basically lymph nodules or follicles, or you also see it called germination centers. And then the inside would be, the middle of it would be that medullary cords, these things here. Okay. So really what you got to tell me about this is that this is a lymph node. Okay. So you want to make sure you look at some of these for lymph nodes. We okay with this one?
We just need to know that the whole thing
Is a lymph node. You betcha.
So we don't need to point out the follicles and medullary cords?
No, I wouldn't worry too much about it.
I got the video.
Okay. So this is spleen, and in the spleen, the two things you got to know is red pulp and white pulp. Do you see the red pulp? Do you see the white pulp?
Yeah, I think so.
Yeah. Okay, so the white pulp on these things stains blue, and so these blue areas like this is white pulp. I know you're going, wait, that's blue. No, but that's really white pulp.
White pulp.
The areas around it is red pulp. So what the white pulp has is where you have a lot of your lymphocytes and leukocytes that are sitting there because there's immune function in the spleen. The red pulp is where you're basically filtering blood and removing old blood cells and stuff like that. And your, so if you have your spleen removed, you are more susceptible to certain bacterial infections, and you actually have to get vaccinations. So be able to identify this as spleen and the areas of red pulp and white pulp. Like here's again white pulp. Another white pulp around it is all red pulp. Okay. So I'm not. It should. Any questions about this? I guess. Those are the 3 slides for lymph. Okay. And towards the last week of school, before you guys have your test, like the week before, I will focus you on the slides and give you a better idea of what's going to be on there. Because we've got GI slides coming, we've got some respiratory slides, we've got some urinary slides, and we definitely have reproductive slides coming yet. So there will be microscopes on the last test. Okay? Everybody okay with this? Okay, so you've still got a little bit of time to work on any of this stuff that we did.